I know from the list here, we've got people from all around the world. So good morning, good afternoon, and good evening to all the different people who are here. And yeah, it's a great opportunity. I mean, so what we have are an excellent program. We've got 6 short talks from different members of St Paul's Eye Unit in Liverpool and the University of Liverpool. And we have sort of a few cool things to illustrate. So this is the 150th anniversary of St Paul's Eye Unit in Liverpool, which if you're local, I'm sure you already know of. But our first talk is going to be from Professor Simon Harding, who's going to tell some of the history of the local organisation and the impact it's had on the town. Then as we go on, we'll have Matt Roney, who's on the screen at the top there. You can have a wee wave, Matt. There we go. I don't know if you saw that or not. It's hard to know what other people are looking at. But, so Matt Roney is an optometrist, and he'll talk about the importance of having a regular eye exam. And then next we'll have Victoria Kearns, who's also here, nice wave there, who's a senior lecturer on the university side. And she'll talk us about how she's using oils to deliver drugs, and it's more of a research angle. We'll have Austin McCormick, who I'm not seeing at the moment, but he'll be in here somewhere, who's going to talk about eyelids and eyelid cancer. And then we'll turn to Toby and Vito, whose video is turned off at the moment, who'll talk about the cornea and its function. And so we're basically going to get a nice little flavour of a lot of the different things going on in Liverpool. By no means is this everything. Oh, there's Vito now. But it certainly will give us a nice touch on everything. Throughout the chat here, just because I know people have joined since, feel free to ask questions, but when the presenter's talking, can you please ask questions using the chat function? So in the bottom middle of your screen, you'll see a little speech bubble icon. If you click on that, and then you can write your questions in the top, into the chat box. And then after the talks, I will open the floor up. I'll ask some of the questions from the chat, but we'll also invite people from the audience to join in. So the more you join in, the more engaging this seminar will be. Just before we begin, I'm also going to highlight just now, since I don't want to start too early, that we have another session, Ask the Expert session on Saturday, that will give you another opportunity to ask questions. And throughout this week, which is a really important week for eye health, we actually have a number of other videos being posted online. I'm going to provide all the links for them elsewhere. Now, why is this a really important week for eye health? Well, on the 6th of June, so 6/6 and 2020, those are 2 significant numbers. 6/6 in the UK is the number, I'm sure Matt will correct me on this, is the number that means perfect vision, or yes, thank you, good. Whereas 2020, as I'm sure you've seen on TV, is the US equivalent. It's the version of perfect vision in the US. So 6/6/2020 says eye health all over it, and we've been on board that for a long time, so we thought this would be a great opportunity. How are we feeling? 33, we have 87 people on. Don't worry if you've just joined, you haven't missed anything important, just me blabbing on. I think maybe it would be appropriate to hand over to Simon Harding to share your screen and probably start the first talk. If for the rest of the audience, if you could remain muted during the presentations, that'd be great. Okay, thank you. So over to you, Simon.
Thank you very much, Kevin. It's a great pleasure to be speaking to everybody on this momentous occasion. I've been asked to give a history of the St Paul's Hospital and Unit, partly because I'm now, I think, the oldest person still working here at St Paul's Eye Unit, which says more about me than anybody else, I think. I'm going to start the story off with back in 1871, when St Paul's Eye and Ear Infirmary was founded by George Edward Walker. You can see him on the left here, and this was the building at St Paul's Square, which was the first building to be occupied by St Paul's. Now, and more about the Walker family in a moment. There was another Eye and Ear Infirmary, which opened in 1840 the Liverpool Eye and Ear Infirmary, and one of the most notable ophthalmologists there was Francis Chavasse, who developed a lot of innovative squint surgery, and his name is still remembered in Chavasse Park from the family, and also in the Chavasse unit at Alderhay Children's Hospital Department of Pediatrics. St Paul's Eye Hospital opened in 1912 after an appeal which was led by the philanthropists of the city. I'm introducing George Edward Walker's son here, Arthur Nimmo Walker, which is my first reference to the Booth family. And we're going to hear from Doug Booth later, whose grandfather was a friend of Arthur Nimmo Walker, the son of George Edward Walker. And the Booth family, which ran a very famous shipping line at the time in Liverpool, were instrumental in developing a lot of work around the fundraising. The Eye Hospital got going on Old Hall Street. Here's an image from shortly after that. In the distance, you can see St Paul's Eye Hospital. The clinics at that time, around about the 1920s, were absolutely rammed busy. Those of you that come to the hospital and the unit now will still recognize these sorts of packed waiting rooms, but thankfully we do have seats most of the time. In the 30s and right the way through the 20th century, specialisation started off. I mentioned pediatric ophthalmology with the Chavasse unit. We started off with glaucoma specialisation. You can see Roy Mapstone on the right here, those of you that remember any of the consultants from the 1980s. Vitreoretinal surgery started off with Tony Gray, and the first corneal transplants were done in Liverpool by Alan Patterson. Specialisation was a really important part of developing ophthalmology around about this time. You can also see some of the more later appointments. I'm hidden here somewhere with very long hair, quite similar to what it looks like now. I'll show you at the end of this. You'll recognise some of the other consultants that were appointed around about that time or were being trained. That eye hospital, the second iteration, closed in 1992 and moved to the current setting at the Royal Liverpool University Hospital. Now, I was thinking about how the unit has changed since that move in 1992, when we had 5 senior staff at that time. Look at how many professors, readers, consultants we have at the moment. It's a phenomenal change. And as I say, I think that has been partly developed through specialisation. We've brought in experts from around the world to come and work here in Liverpool. At the same time, we've expanded research considerably. We started with a unit of ophthalmology in 1992 under my predecessor, Ian Grierson. And then we developed a clinical eye research centre opened by the 19th Earl of Derby, you can see on the right here. This clinical eye research centre really gave our clinical research a big boost. And looking at the recent figures, we have 34 clinical research studies going on at the moment, recruiting hundreds of people every year to clinical research. And this also makes me, prompts me to talk back again about Arthur Nimmo Walker and his connection with Alfred Booth. Arthur Nimmo Walker identified ophthalmia neonatorum as a condition that was caused in newborn babies by gonorrhea, and was described by him and could possibly be the first piece of research that was published from St Paul's Eye Unit, St Paul's Eye Hospital in those days. Now, out of that clinical specialisation, developed our academic unit that Kevin talked about a moment ago. And here I've listed, I'm not going to go through all of these, some of the research teams, the fundamental research that is taking place now here in Liverpool in our Department of Eye and Vision Science. We're studying the diseases in the middle column, and we have all of these facilities that have been built up since we moved from Old Hall Street. This has been supported very heavily by the Foundation for the Prevention of Blindness, which was set up when the Eye Hospital moved to the Royal Liverpool Hospital. Since that time, generous donors have allowed the foundation to support the development of research to the tune of £5.4 million. Now, that has been translated into a huge amount of research. And looking back over the last 3 years, grant income coming in from other research funding bodies has averaged £2.75 million a year. And that's against a contribution of the foundation of about 250,000 a year. So it shows you that this sort of research can be underpinned by charitable donations, by our generous, warm supporters, and that multiplies up by a factor of 10 to 1. A few years ago, we received the Freedom of the City in recognition of all this work. And now we look forward to 2020 and beyond. Well, we're looking at the 4th iteration of St Paul's Eye Unit in the new Royal Liverpool University Hospital, which will open in the next couple of years, in spite of the faltering attempts over the last few years. And we're going to be right at the heart of the Liverpool Knowledge Quarter. We've also merged with colleagues at Aintree University Hospital, and we're also going to be working very closely with colleagues at the Department of Paediatric Ophthalmology. So I hope I've given you a flavour of the sorts of history, the way research is linked right through our lives here, and the importance of our specialisation. Before I hand back to Kevin, I just want to play a special tribute to Tom Southern, who spent a huge amount of time setting up this session and ably supported by Michelle Masters. So I'm going to try and show my face so that you know that I am actually here, and then pass back to Kevin. Thank you very much.
Very good, Simon. So just, we're going to keep moving through, but before we do that, we have the greeting from Doug Booth, who is, well, he tells you himself in the video. I just want to share that with you just now. It's very short. We see that okay? Yeah.
Greetings from New York City, amid strange times which challenge us to join together with intelligence, heart, and dedication to create a brighter future for us all. I'm honored to be addressing you on behalf of my great-grandfather, Alfred Booth, who worked with Arthur Nimmo Walker to strengthen and expand St. Paul's Eye Hospital quite some time ago. It was a groundbreaking institution in its day, which wonderfully, as you all know, and thanks to the efforts of many here today, has continued strongly into this new century to ensure that the light of the world will continue to illuminate the lives of many who would otherwise live in darkness. Although I never knew my great-grandfather, from what I've read in family histories, he was a caring individual who saw his community as an extension of his family and acted accordingly. And I am proud to be his descendant. And I do have to mention, I spent a summer 52 years ago living and working in Liverpool with the job of painting X's on defective concrete I-beams, during which time I developed a great affection for my ancestral homeland and this community, as well as picking up a smattering of Scouse, so no one could understand me when I went home. I look forward to quintupling my awareness of sight and vision and the work of St. Paul's Eye Hospital during this gathering, and I'm happy and honored to convey what I'm sure would be the warm and congratulatory greetings of my great-grandfather Alfred to you all.
So yeah, I don't know what else to say apart from I really enjoyed receiving that message. I think what we'll do is we'll move straight on with our program. So I'm going to hand over to Matt now, who's going to talk about things.
Perfect.
Matt, it's all yours.
Thank you. There we go. So thank you so much for asking me to talk today. My name's Matt Roney. I'm a specialist optometrist here at the Royal Liverpool University Hospital, and I'll be talking to you today about the importance of a regular eye examination. So as I say, thank you for the invitation. It's an honor to be here talking to you today. So what is an eye examination? And many of you may know this as a sight test carried out by an optometrist in an optician's. But rather that the College of Optometrists would rather that we move away from the term sight test and rather call it an eye examination. There's the common misconception that patients just go to see their optometrist merely for contact lenses, as well as spectacle prescriptions. Optometrists can do more than just check prescriptions, also known as refractive error. So who is having an eye examination each year? Well, NHS England have shown that a good proportion of the population are having an eye examination, 13.2 million to be exact. But general trends have shown that year on year there has been an increase in the number of eye examinations each year. However, the RNIB, the Royal National Institute for the Blind, have shown that this is not enough, and that 13.8 million of the UK population are not having a routine eye examination. But you might say, well, why is this significant? Well, the World Health Organization, WHO, have shown that 80% of all visual impairment is preventable. So you might be saying, well, what is involved in an eye examination? Well, being an optometrist, and I'm very proud to do so, is a multidisciplinary role. And the role of an optometrist has changed quite significantly during recent years. This is due to the undertaking of optometrists carrying out higher qualifications, so furthering their learning in specialist subjects such as contact lenses, glaucoma, low vision, as well as pediatrics. As well as undertaking work by local hospitals. So for instance, here in Liverpool, optometrists in the community, so working in an opticians, can carry out post-operative cataract assessments on behalf of the hospital. But let me run you through the run-of-the-mill eye examination. So what is involved? Well, your practitioner will ask any presenting concerns that you have when you first come, asking questions related to symptoms, general health, ocular health, medication, as well as any other questions that are deemed necessary based upon your presenting concerns, such as headaches or double vision. After which, they will check what we call the refractive error, which is the glasses or the contact lens prescription, ensuring both optimal vision at distance and up close, so a reading prescription, using different lenses with the dreaded better with or better without, and better on the red or better on the green. I still can't tell after many, many years. But some consultations do not include this better with and better without. Don't worry about that. That's perfectly normal. For instance, examining children are less responsive with regards to determining which is better with and better without, such that the optometrist may hold up different lenses and shine different lights, helping them determine the prescription. Or they may even use a special machine to do so. So after which, optometrists will generally check what we call binocularity. This is the term for how your eyes work as a team together, and this gives quite a big insight into visual development of anyone. You might be able to see in this instance that the left eye of this young boy, so on the right-hand side of the screen, the eye is turned in towards the nose. This is called a strabismus, or what other people may know as a squint, or a funny turn in the eye. This strabismus, also known as squint, can result in the eye becoming lazy and developing a lazy eye, known as amblyopia. So it's imperative that this is addressed as early as possible in childhood to ensure adequate visual development. After which, the optometrist carries out a thorough eye examination at both the front and the back of the eye using a large microscope called a slit lamp. You put your chin on the rest and it allows the optometrist to look at both the front and the back of the eye. So when should you have an eye examination? I think that's a really key question, but in my opinion, you shouldn't just have an eye examination when you're having problems with your eyes. It should be rather as though you're going to see your dentist, in a sense that people go to see their dentist not just when they have toothache or a problem with their teeth, but they go for a regular checkup. And therefore, I would suggest that you should go and see your optometrist as though you're going to see your dentist in some ways. Bourne and colleagues in 2017 carried out a study which showed that 2.2 billion of the global population have a visual impairment. This is significant in a sense that 1 billion of those 2.2 billion, their visual impairment could have been avoided, prevented, or are yet to be addressed. So why should you have an eye examination? Well, to ensure optimal vision at distance and at reading, to ensure you can see as clearly as possible. To ensure correct visual development from when you're a child up through to adolescence. Ensure that your eyes are as healthy as they can be to ensure that you have the best quality vision possible. And if present, to identify and manage ocular pathology at its earliest stage, and if so, referring you on to see an eye doctor. So what kind of disease am I talking about that is preventable? Well, this is cataract. Cataract is the clouding of the natural lens in the middle of the eye. The lens sits just behind the colored part of the eye, called the iris, and it's perfectly normal age-related disorder of the eye. And it is generally easy to correct. Signs of cataract are able to be picked up by your optometrist. This slide shows the effects that cataract can have on your vision. Cataract can take your vision from being crisp and clear to blurred, with glare, or even with cloudy vision. And as said previously, this can be picked up by your optometrist and subsequently referred to an eye doctor, also known as an ophthalmologist, to remove the cataract and replace this with a man-made lens, generally reversing the effects of cataract, taking it from being blurred or cloudy back to being crisp and clear. This is another disease of the eye. Well, this is the picture of the optic nerve, first of all. And this eye, the nerve of the optic nerve itself is located at the back of the eye, and it runs from the eye to the brain, supplying information to help us see. This nerve, unfortunately, has been affected by glaucoma. Glaucoma is damage to the eye, generally caused by high pressure within the eye. And this high pressure can be picked up with the dreaded puff of air test. One that goes poop. So how does glaucoma affect your vision? Well, glaucoma, unfortunately, is a silent disease. A lot of patients don't know that they have glaucoma until it becomes very advanced. And glaucoma doesn't affect your central vision in the early stages, but rather your peripheral vision. So this is the part of your vision that is slightly off to one side when you're looking directly at something. And as I say, a lot of patients are asymptomatic or without problems until it becomes very advanced, and then it starts to affect your central vision. A visual field test is carried out routinely in an eye examination if it's required to do so. This reminds me of a patient who I've seen in years gone by. And this gentleman always sticks in my mind. He was a 63-year-old male who had never had an eye examination. But he went to his optometrist in an optician's because he thought that his reading vision wasn't getting as good and he needed some slightly stronger glasses. Although he did need slightly stronger glasses, it was found that he had quite advanced glaucoma at the back of the eye. And this subsequently had affected his peripheral vision. And this highlights that this gentleman didn't have any problems, really, apart from requiring reading glasses, but that actually had something else manifesting itself on the unknown. This is another disease of the eye. This is diabetes at the back of the eye. And this patient actually didn't know that they had diabetes and it was unknown to them. but diabetes can manifest itself within the eye. And this is called diabetic retinopathy. It's a fancy term for diabetes within the eye. In this case, you might be able to see that there are red splodges. This is blood. And this is because the blood vessels within the eye, when you have diabetes, become slightly more brittle and fragile, such that they're more susceptible to breakages and subsequent bleeding. You might be able to also see that there are some central yellow dots within the center of the screen. This is called exudates. This is leakage from the blood vessels, which are brittle and fragile, and they've leaked out, such that diabetes can cause a visual impairment, and it can be either mild or quite severe in some cases. This reminds me of, once again, an anecdotal example of a friend of mine who unfortunately didn't know that he was diabetic until he went to see his local optometrist, who looked at the back of the eyes, and similar to this presenting picture, he wondered whether he did have diabetes. The optometrist said, I think you should go and see your GP to make sure that you're not diabetic. The GP carried out the required investigations, and actually it did turn out that it was that the gentleman was diabetic. If you want to know more about this disease, Professor Simon Harding, who gave the introduction, yesterday spoke on diabetes. This is available via the Eye Revealed 2020 webpage, and you're welcome to view that at your leisure. Anything that affects, well, generally anything that affects the body can also affect the eyes. In this instance, blood pressure. This eye, the back of the eye here shows blood pressure changes, and blood pressure that manifests itself at the back of the eye can cause visual impairment. These arrows show changes in the blood vessel path, as well as the caliber of the blood vessels. And this can cause, similar to diabetes, in a sense that you can get bleeding and leakage of the blood vessels, but also in some instances, the high blood pressure can cause blockage of some of the blood vessels and subsequently reduce the amount of blood going to the back of the eye, causing structural damage to the back of the eye, unfortunately. An optometrist during a consultation would be able to see this and should be able to pass you on to the relevant people to manage this. And finally, refractive error, known as glasses prescription. So really, what is the take-home message of this presentation? I would strongly urge you to have a regular eye examination with your local optometrist. And NHS England recommend visual assessments from the age of 4 to 5 years and younger if there are visual concerns. Optometrists can look at more than just glasses prescriptions and contact lenses. I would strongly urge you to seek advice or an examination when you have a problem with your eye. For instance, a red, painful eye, please do go and see either your optometrist or your eye doctor, an ophthalmologist within a hospital. And a regular eye examination is vitally important to ensuring good ocular health as well as optimal vision. These are references that I have made to articles as well as studies. You're welcome to view those at your leisure. If you have any questions, I'd be more than happy to answer them. I hope that you've enjoyed the presentation, and thank you for asking me to speak today.
Very good, Matt. Maybe if you stop sharing your screen just now.
Yep.
I see we have a few questions in the chat, and a lot of them are to do with how frequently one should have an eye check. And Professor Harding has actually provided an answer. I'm not sure if you can see the chat, Matt, or not.
Yeah, I can see the chat.
Yeah, so in case anybody else can, there are various forms of the same thing. Should we? How often should you be getting it? Should you be getting them yearly? Should you have it more frequently as you get older? If you already have a sight problem, should you be checking your eyes more frequently? And then Simon's put in a really nice comprehensive answer. I don't know if you want to add anything.
Yeah, I agree. I think the main thing is that when you see your local optometrist, I think the optometrist is keen to give a suggestion of how often you're to be seen based upon your clinical findings. So whether you've got a family history of any eye disease, whether you've got anything that he or she wants to keep a watchful eye on, but generally above the age of when you move into adolescence, how often you should have an eye examination is roughly every 2 years in general. But take advice from your optometrist about how often you should be going.
Okay, and I have another question here, which is a sort of variation of that theme. If your eye examination finds that you could benefit from glasses, is it true that if you start wearing the glasses, that your vision will get worse more rapidly?
So that's a common misconception, and that's not the case. I think really what people notice is when they put their glasses on, they're able to appreciate what the vision is like with glasses and without glasses. And really it's highlighted that the perception, their vision with glasses is much, much better. So no, it's a common misconception that glasses make your vision worse. That's not the case whatsoever.
Yeah, as a glasses wearer, I can attest to all that. I did notice there was a few questions not within the chat. Is it Cheng Zihang? Would you like to unmute your microphone and ask your question? Or perhaps it's
Oh, hi. Sorry, no, that was a bit of a technical error on my part.
Oh, okay.
I was just viewed the comments earlier, but it's a very good, nice talk, Matt.
Thank you.
No worries at all. Just to try and stay on schedule, I think what we'll do is we'll move on to the next talk. So I'll invite Victoria Kearns to share her screen and her video. Anybody else who has questions that we haven't been able to deal with just now, please feel free to type them into the chat box, which you can access in the middle bottom of the viewer window, or we can certainly continue to take questions as we go, because there's a lot of eye experts, not just the ones talking here. There's actually a few other ones in the chat as well. So if you have a question, please feel free to ask. But if I could hand it over to Victoria, that would be super.
Okay, thanks Kevin, and thanks everyone for attending. So my talk's going to be a bit of a change of direction. I've been asked to talk to you today about some of the research work that my group is doing in Liverpool. Don't worry, I'm not going to bombard you with graphs or anything like that, but I'm just trying to give you an idea of some of the things that we do both in St Paul's and at the University of Liverpool. And what my team is doing is to try and come up with new ways to deliver drugs to the inside of the eye. Because as Matt's just said, diseases involving the back of the eye are really important. They can lead to sight loss and for lots of people, which really reduces people's quality of life. And also for people who are of working age, it really affects their financial opportunities. And these are the diseases that I'm talking about include things like diabetic retinopathy and age-related macular degeneration, and those things affect millions of people worldwide. So I'm an engineer, and what Liverpool has is a really unique expertise in ophthalmic bioengineering. So this is the use of engineering skills to treat eye diseases. And what we do is we work across different departments and faculties in the university and in partnership with our colleagues at St Paul's. So this means that we can combine expertise from different areas. So I've highlighted some of those areas here in my slide. Hopefully you can see my cursor. So we've got clinical expertise. So that's from ophthalmologists, but also other healthcare professionals such as Matt, who you've just heard speaking, but also importantly, patients. And they're important because they can tell us what things are really important to them. It's really, it's all well and good everyone else thinking what's important, but I think patient input is really important, and this is really helpful when we're designing new treatments. We also have biological expertise in a variety of areas. This includes things like understanding genetics, how diseases occur and how they can be treated, and as well as things like how drugs move within the body, which is really important to my work. And we also have a wealth of physical expertise. This includes things like chemists who can help us design new molecules for delivering drugs. Lots of engineers throughout the university who can help us understand all sorts of things like the structure of the eye. They can help design new surgical instruments and design computer software that can teach computers to spot signs of eye disease in images that humans can't. And what I try and do is work with people from all across these different specialities to engineer solutions for patients. And although I'm going to talk to you about my work, Bioengineering in Liverpool is not just about what I'm going to talk to you about today. There's lots of other work going on, things on engineering new tissue, developing more accurate ways to measure pressure in the eye, and designing new bandages to treat injuries to the front of the eye, to mention just a few areas. And there's much more information on that available on our website. But one of the first parts of research I'm going to talk to you about is about silicone oils. Now, silicone oils are used in the eye to treat retinal detachments. So retinal detachments, and I've tried to show here in a diagram, are where the retina, which is here, is this yellow line, comes away from the back of the eye. And that's the most common sight-threatening emergency in the UK. It affects about 1 in 10,000 people each year, and is rare in people under 16, but more common in people who are 60 to 70 years old. And some of the risk factors for that include you being very short-sighted, so more than 6 diopters, people who've had recent trauma to the eye, and also recent eye surgery. So what the ophthalmologist wants to do is try and get this retina to attach back to the back of the eye. And in severe cases, particularly where there are multiple breaks in this retina, you might treat it with silicone oil, so that clear vitreous jelly, which fills up your eye, is removed. The breaks can be repaired, and then your eye would be filled back up, as on the picture on the right here, with silicone oil. Now, silicone oil is hydrophobic. It repels water, and this means it can help keep fluid, so the fluid I've tried to show here, away from the wound site. And this hopefully reduces the chance of getting scar tissue and lets the retina heal as best as possible. Now, Liverpool has a world-leading team when it comes to silicone oils and their use in the eye. And although not involving myself for all of this time, the team has been working on them for more than 25 years. And they've come up with really important insights and discoveries as to how these oils work in the eye. And one important one, and that will hopefully explain this picture, is around emulsification. So if you think of my previous picture, I showed that we had an eye full of oil once it's been treated, but there's also a little bit of water in the eye. When you've got water and oil in the same container, as we've got here in my picture of salad dressing, if you shake that up or move your eye around, for example, you can get emulsification. So when you shake your oil and vinegar, you get a cloudy phase of salad dressing, which is exactly what you want. However, in your eye, if you're shaking oil and water around, having something cloudy will affect your vision, and you don't want to have that. And it can also cause other problems in the eye. So one of the things that the Liverpool team in the past discovered is why this happens, and they also invented technology that is used in new oils, such as the ones I've shown here, that reduces the chances of this emulsification happens. So these are used throughout the world now, based on technology that was developed here in Liverpool, and leading to better patient outcomes. But despite these advances, there are still some problems that happen with people who have been treated with oil, not just because of the oil particularly, but because of their underlying retinal detachment. And some of them can develop scarring. So I've tried to show here some of the scar tissue that they might get. This can happen from retinal detachment, but also in the later stages of diabetic eye disease, when you develop proliferative diabetic retinopathy. Now, scarring at the back of the eye is similar to a scar you can get anywhere in your body, for example, on your skin. So if you think about a scar on your skin, it doesn't, quite often it might not heal to get the perfect structure of the skin that it did before. So here's some pictures of some scars that you can get at the back of the eye. So the white tissue here is scar tissue, and you can see that it's got some lines of tension here. And if you think about the scars you might see on your skin, sometimes they can get a bit tight and pull at the skin and distort it. This can happen at the back of your eye with your retina. And this type of scarring is sight threatening, and it can distort your retina, threaten your vision, and pull the retina back off again. And lots of people have tried to use drug treatments to try and reduce this scarring, but nothing yet has been proven clinically to be effective. So what I wanted to do is to see whether we could use silicone oils to deliver anti-scarring drugs. because these oils are already going to be in the eye, so they could present an ideal opportunity to use them as a reservoir to release drugs. And other people have tried this before. They've tried mixing drugs in, but it hasn't been effective. And this is probably because it's actually quite difficult to get enough drug into the oil. And when you do, it comes out too quickly. So the two challenges really are getting enough drug into the oil in the first place and allowing it to be delivered over a number of weeks, because that's the time period over which the scar happens. And I've referred here to Goldilocks drug release. So I've got a 2-year-old daughter, and I spend a lot of time reading Goldilocks and the Three Bears at the moment. I'm sure most of you are familiar with that, and the concept of the porridge being too hot, too cold, or just right. Well, I'm trying to achieve something like that with my drug release. I want to be able to get drug release that's not too much that it's toxic to the eye, not too little that it won't treat the eye disease and the scarring. I want it to be just right. So where are we now with this technology? So as I was thinking about this, I've been working on this for almost 9 years now, which seems a long time. And I've been working with polymer chemists at the University of Liverpool to come up with new ways to add drugs into these oils. I'm not going to give any technical details, although I am more than happy to share with anyone who is interested. But what we can do now is we can get more drug into the oils than if you just mix it in. Our technology allows us to do that. And we have been able to get this drug release over a number of weeks, which is the clinically important period. What we're doing is we're working to put this technology into existing products. So we're working with a German company who makes silicone oils, because they've got the expertise in what we do is we make things in the lab. They've got the expertise to make this on a commercial scale and help pass all of the regulations that are required. But also working with colleagues in Liverpool. So Liverpool doesn't just have the expertise in developing new oils, but also testing them in patients, which is really important if we want to be able to get this technology into the clinic and help treat scarring in patients. So silicone oils are only used in the treatment of retinal detachment. And there are lots more eye conditions that aren't suitable for delivering drugs this way, such as age-related macular degeneration and diabetic macular edema. But these are things where it is actually important to be able to deliver drugs. So Matt before talked about the formation of these leaky blood vessels in the eye. And many people receive an injection of a drug, as I've shown here on the right, designed to try and stop the formation of these new leaky blood vessels. And patients may receive repeated injections every month or so, depending on their circumstances. And this can be quite uncomfortable. I've heard from speaking to patients in the clinic, and I know that some of our listeners will have attended very busy eye clinics to receive these types of injections. So what my team is trying to do is design an injectable system where the drug will be released over many months, so that patients don't have to keep coming back to clinic to have these frequent injections. And what I want to do is do this using a nanomedicine approach. So nanoparticles are tiny particles that are hundreds of times smaller than the width of a human hair. And they're already used in a range of common products that you will have come into contact with, such as sunscreen, clothing, and household paints. So they are quite a common technology already. So it's not about necessarily making new drugs, but making commonly used drugs into a new size, because that makes them into a class of medicines called nanomedicines. And these nanomedicines can have really exciting properties. In particular, you can deliver more drug from a single dose, and you can combine these with a slow release system so that it could be released over many months. The Liverpool Nanomedicine Group is actually world leading. It's got really promising technology for other diseases such as HIV, where they're delivering antiviral drugs. And of course, at the moment, the delivery of antivirals could be really important in treating COVID-19. But we wanted to see whether we could apply nanomedicine technology to eye disease because of its huge potential. So we're at a much earlier stage than we are with the oil project, but what we're doing is we're developing a nanomedicine formulation that contains two nano-sized components, drug nanoparticles, so of an existing drug, just made much smaller, and something we call a nanogel. And when we mix these two things together at room temperature, they're a liquid which can be injected. But when we inject it into the eye, because the eye is a little bit warmer than the room, or hopefully it is, and that there's some salt naturally present in your eye, these liquids, once they're injected, become a gel that can sit in your eye softly and hopefully release the drugs over many months. This will hopefully mean that we don't have to have patients coming back to clinic so often. So at a much earlier stage of this, as I said, we've been working on this for a couple of years, but we do have all this pre-existing knowledge from the Nanomedicines group on other diseases, as well as all of the expertise that our clinical colleagues at St Paul's have in treating patients with diseases, and the Clinical Eye Research Centre's expertise in testing new drugs. So at the moment, we're right in the middle of making and testing these new nanoparticles. We're using a drug that's already used to treat diabetic edema, but it's not used in a nano form, and that's what we're trying to do. And we also know that we can make the gels that I described to you previously. So what we've been doing, I won't give you too much details, but we've been getting dead pig eyes that are a waste product from the meat industry. And we can inject our gels into those eyes and show that we can get this nice gel formation. So we're really hopeful of developing technology that will be able to bring benefit to patients, although it might still take us a bit of time to get there. So in summary, I hope I've given you a taste of some of the research that Liverpool does, and some, although of course not all of the areas where we have world-class expertise, that both on the academic and the clinical side. We're really hoping that we can use this to come up with solutions to problems and sight-threatening diseases that don't currently have effective treatments, free ophthalmologists and other healthcare professionals to spend more time with their patients, but most importantly, prevent patients from losing their sight. Thank you.
That was excellent. Thank you very much, Victoria. As you know, I'm a big fan of this. This is stuff that can really push forward treatment, make things a lot easier for people, have fewer injections. All that sounds just fantastic. We have a really good question here, actually. So what is the advantage of the gel formation property of the nanomedicine in the eye? Why can't it just be used as a liquid?
Oh, that's a really good question. Well, one of the answers to that came from conversations I had with Professor Pearce. He highlighted the fact that being able to remove an implant once it was in there is actually something that ophthalmologists would really want to do, because although we hope that our implant wouldn't cause any problems, being able to remove it would be a real advantage. So that's one of the advantages. And another advantage is that having it all together in a gel actually helps us control the drug release because it's all together rather than having it swishing about in the eye.
Yeah, very good.
That's a technical term, swishing.
Swishing about, yeah, I thought as much. This maybe maybe this is a question for a clinician, I'm not sure, but do you know how much it costs for the clinical, to get an injection into the eye? Because that's, I guess, what you're going to be saving, the NHS or the taxpayer or the insurance company in the States.
I would like to refer that question on to Professor Harding. He might have a better idea of that than I do.
Are you talking about the cost of the delivery of the injection? In which case that would probably be around about £200 to £300. So for a silicone oil, that's a one-off, but for the nanomedicines, which would have to be given on a regular basis, then it starts to add up. And people usually forget to add that to the cost of the actual drug. So some of the treatments that Victoria was talking about are very common now. People get them every month. The drugs might cost between £500 and £1,000, which is pretty steep. But then you've also got to pay for the likes of me to put them in.
So I think that it's a really big deal. So it's not just better for the patients, it's better for the economy as well. There was a question earlier on, which is, can a replacement lens be inserted when the initial lens blurs, which I think also refers to when the oil becomes emulsified as well. That could also become relevant. can you get it back out again and put fresh stuff in?
Sorry, can you ask that again?
I think I was in the process of trying to write a written response to you, Brian, about that, but I wasn't quite sure if you were referring to the general cloudiness of the lens that occurs in cataract, or whether you were referring to a lens that that you or somebody you know might have had to treat cataract that has then gone cloudy. So if you'd like to maybe either unmute yourself and say which one you'd like us to talk about, or put something back on the chat, and then I'll try and answer.
It's on. I've unmuted it. Get going. It's too shy. It's from a replacement lens after a cataract following glaucoma. It was quite complicated. It was a difficult surgery, and if it can be replaced again as it's starting to become cloudy.
Yes, it usually can. It's a much more of a challenging operation the second time round. And so, you know, you have to weigh the risks and the benefits a bit more carefully than we do even for a routine cataract operation. And if a person has had glaucoma as well at the time of having that cataract operation, that makes it a bit more complicated. So, yeah, we can explore that a little bit further after this, if you wish.
Thank you.
But the answer is yes, but it's challenging.
Thank you.
Here's an interesting question. So, do treatments at the back of the eye pass to the front segment, or can you use treatments and technologies remain segment specific? So for the general audience, the lens kind of sits in the middle, and then we think about the eye as the anterior segment in front of the lens, and behind the lens is the posterior segment. So the question is, if you squirt something in the back, does it stay in the back, or does it transfer to the front as well?
Well, this, in particular for our nanomedicine work, this is actually something that is really important to understand, because as well as all of the exciting properties that nanomedicines have in terms of ability to potentially treat or be more powerful, they also move in the body in a really different way, or body in the eye in a different way to standard medicines. So that's something that's really important to us that we will need to know. So we know with other treatments what happens to them in general, but that's something that with our nanomedicines that we'll be paying particular care of, because we want to know exactly where these nanomedicines go once they're released into the eye. But we hope, based on the way that other drugs deliver, or other drugs behave once they're in there, that they will remain specifically to where they're targeted.
Very good. There's quite a complicated question in the chat. Perhaps I could get you to have a look at that yourself. It's related to carbon-based viscous medium. But what I think we'll do for the interest of time is I might pass over to Austin McCormick next. Austin, I'm just going to unmute you here. Oh,
yeah.
There you go.
Hello. So I'm going to try to share my screen now.
Yep.
Okay, so my name is Austin McCormick. I'm a consultant ocular plastic surgeon, St Paul's Eye Unit at the Aintree University Hospital location. So ocular plastics means surgery to the eyelid and the surrounding area. So you've been hearing lots about the eyeball itself, but as ophthalmologists, we cover the area of the eyelids and the orbit, and that involves quite a lot of cancer work and the opportunity for some research. So why is this important? Well, a figure that really stands out, I think, is that skin cancer is increasing in incidence. There are 150,000 new cases a year in the UK alone of skin cancer. So this is a really big problem, and it's getting worse. And 65% of those skin cancers are something called basal cell carcinoma. And the commonest site for basal cell carcinoma is the head and neck, because it's sun exposed. And of the head and neck, the commonest site is the eyelid itself. And this is thought to be because the skin of the eyelid is the thinnest on the body, and therefore offers less protection against ultraviolet light. And it remains that ultraviolet light is the major risk factor for getting skin cancer. There are other factors that can increase your risk, but the main risk factor is still ultraviolet light. And you don't have to have been abusing sunbeds all your life, although that clearly is a risk factor. You know, normal exposure over a lifetime in this country is enough to cause skin cancer. Just to warn you, there are a couple of pictures coming up of some of these little skin cancers and a couple of photos of what happens before, during and after surgery. So I'm not trying to frighten anyone off, but I think hopefully you'll be able to see that we can get really good results. And I certainly see people who have delayed coming to see a doctor about one of these things because they're frightened of what might happen to them. And hopefully I'll show you that we can get very good results, both functionally and cosmetically. So what we're looking at here is this lesion. This is a relatively large one. They start off very, very small and they grow very small. So if you've got a scratch or a little lump that's not healing and that is growing, you should get that looked at. So this is a basal cell carcinoma. And here on closer inspection, you can see it's got a sort of a shiny appearance, it's raised, there's a little bit of a scab or ulcer here and funny looking blood vessels. What we've got to do as ophthalmologists and also as optometrists in the community is to recognize what is something that could be a skin cancer and what's not. So here we've got an upper eyelid that's swollen, but actually this turned out to be a sty and it settled down and didn't need a biopsy or anything like that. One of the key things we're looking for in eyelid skin cancer is loss of eyelashes. Cancer will grow through tissue and destroy anything in its wake, whereas a simple cyst won't. And so you can see here the eyelashes have all been preserved. This lump here actually is pretty similar to the last one, but this one is actually a skin cancer of the eyelid. However, what you can see is very clearly eyelashes have been lost, and there's a big asymmetry between the upper and the lower lid, as well as the rest of the eye looking angry. And here again, loss of eyelashes and the normal anatomy. You see the normal anatomy of the eyelid where you've got this nice flat top to it and smooth edge has all been lost. So at this stage, most of us would recognize a GP or optometrist or ophthalmologist that there's something going on here. But you can imagine if it was just a little area like that with the rest of the lid looking normal, it could look a bit like a sty in the early stages. The difference is a sty is going to get better fairly quickly, whereas these things progress. And again here, some of these changes can be quite subtle. If you're not looking closely, you might miss the fact that there are loss of eyelashes and the lid margin, which is nice and clean here, has become a little bit lumpy. So here's one that's been removed, and the simplest way of correcting some of these problems is to simply close it directly. And the end result can be extremely good. So a lot of people, because it's their face, are very worried that they're going to be deformed or disfigured by this sort of surgery. And I think it's important to inform people that that's not necessarily the case at all. The vast majority have an excellent outcome. In fact, someone like this might be saying, oh, you should have removed a bit of that excess skin down there as well while you were at it. But we obviously can't do that. Another example, quite subtle, but actually the extent of the changes was like that, with a defect like this. And some of the reconstructive techniques we have use tissue borrowed from the upper eyelid. You can see it bridging down here like that with a little skin graft. And the end result is really good. So good function and good cosmesis. And just one more example, we're seeing younger and younger people, unfortunately, and that partly is to do with lifestyle and people going overseas more, but certainly in Liverpool, where there are a large number of people who use sunbeds. You can see this lesion. This is someone in her 20s who used sunbeds a lot when she was in her teens and has resulted in a basal cell carcinoma with a larger hole in the skin than you might expect from that lesion, and using despite that, in a young person using skin flaps that we can rotate into the area, we can end up with really still good results by trying to create the lines of incision within the normal lines of the face and hide where we've been. And that all will fade really well with time. So that's slightly off there. So one of the things that, so the research we did, myself and Kevin Hamill, was to look at sunscreen application. So we know that ultraviolet light is the main risk factor. And so on a hunch, I thought we should look at how people apply that to the face. because I had a feeling that people didn't really apply it to the eyelids, and yet we know that that's one of the commonest sites for skin cancer. And here's one of the pictures showing that. We were quite surprised at how obvious this showed up. We used a special ultraviolet camera so that the sun screen shows up black, and you can clearly see large areas of the eyelid being missed. But what surprised us also was we then went on and said, we showed this image to the participants and said, well, you've seen where you missed, now put the cream on again, and almost exactly the same areas were missed again. So one of our conclusions there was, it's actually very difficult to apply cream to all of the eyelids. You should do your best, but you probably can't rely upon sunscreen alone, and that having a hat and wearing proper UV glasses also helps. You can see another example there. And this actually produced quite a lot of interest in the media because it's so topical. You know, all of us need to go out in the sun, and all of us need to know how to apply sunscreen. So in addition to sunscreen, you could consider a hat, maybe not something quite as big as this one here, but that might do. Applying cream as widely as you can. A lot of people will find that putting the cream close to the eye causes the eyes to sting, and that puts them off putting it there. But that's fine as long as you also protect your eyes with proper UV filter sunglasses. And again, you've got to be careful there because some sunglasses are just darkened bits of plastic and don't protect against UV. Look for a kite mark that gives you an actual level of UV protection. I thought I'd put this in because this looks like a bit of a hybrid between COVID and protecting yourself from the sun. But this is from an Australian website where they take their skin protection very seriously. And I'd also just add in about vitamin D, because this is kind of contradictory to what we're saying. We know that vitamin D, increasingly, we know that it's important for health, not just with our bones, we've known about it for many years, but possibly also gain protection against infection. And so it's a topic of talk at the moment with COVID being around. It's made in the skin. So if you completely are very good at protecting yourself from the sun with sunscreen, you may then be at risk of not having enough vitamin D protection. How much sun exposure do you need to produce the right amount of vitamin D? Well, probably only about 15 to 20 minutes a day. And so you can factor that in to having some exposure to the sun and then applying cream. The key thing really with sun protection is you must avoid being burnt, because when you have sunburn, that really means you've had a dose of UV light that's reached the deeper layers of the skin, that is certainly associated through research with high levels of risk of skin cancer. In other areas, we're hoping to develop research, some anecdotal evidence, and there's lots of this around, lots of people claiming that cannabis oil or cannabis has cured them of cancer, and obviously we're very skeptical as scientists at heart when we hear this sort of thing. But having seen some examples of cannabis oil having an effect, and actually there being some really good research out there into the cannabinoid system within the body, and we know that the cannabinoid system is, or cannabis oil is anti-proliferative. In other words, it inhibits cell division. This is something we're hoping to look into. Now, we tried a couple of years ago, but actually until recently, research into cannabis products was very, very highly regulated, as you might expect. And so we didn't get very far with that, but the authorities over this have relaxed things a little bit. So we're hopefully going to look at this again, looking specifically at topical therapies for some skin cancers. And this is not something we're currently involved in, but I thought this was really interesting. I mean, I've shown you some pictures of surgery and how we can get good results, but really the long-term future of the management of skin cancer is not going to be surgical. We certainly hope so. As surgeons, we still feel this is a fairly crude way of dealing with skin cancer, to have to cut it out and then reconstruct. Ideally, we would have a tablet to protect us against skin cancer, a tablet or treatment that will reduce its severity once we have it, or even to cure us of it once we get it. And this research here was very interesting, partly because this fish is called a surgeon fish. And it might be that he ends up putting us all out of a job, because in the coral reef biosystem, there is an algae that grows on the coral, and the algae produces a chemical which is taken up by the coral. The coral changes the chemical into something that protects both the coral and algae against ultraviolet light. So a true symbiotic relationship. And then the surgeonfish here comes along and eats the algae, and eats this natural sunscreen, and it protects the fish itself from ultraviolet light. So this was the angle the researchers were looking into, is could we develop a pill that might actually protect us against ultraviolet light? And that research is ongoing. So that's my short presentation, and it's just a little bit of skin cancer around the eyelid. There's lots of other cancers to do with the periocular and orbital region that we're involved with, including lymphoma of the orbit and other rarer tumours. But at the moment, the thrust for our research moving forwards is going to be, we hope, on the skin cancers of the eyelid. Thank you.
Very good, Austin. Maybe you could stop sharing your screen now, and we could
Do that now.
get your face back in the scene. I like to describe Austin as seen on TV, because he did all the ITV and Channel 4 and BBC programs about how to apply sunscreen in the last couple of years. You're famous, yeah. So in the chat, we have a question. Are people that normally burn more susceptible to skin cancer than those that normally tan?
So the first thing to say about that is, if you burn, you are definitely at greater risk of skin cancer. So this is about you as an individual. You have to stop yourself from burning. And it's certainly the case that if you have paler skin, you will burn in a shorter time with lower levels of ultraviolet light. So you need to understand what your skin can take before it burns. You do obviously need to have enough sun exposure to get vitamin D, or take a supplement as the alternative there. So I think some sun exposure is important for natural health, but you must avoid burning. That's the bottom line.
Yeah, so the skin tone itself is a protection against burning rather than a protection against skin cancer. You can still get the cancer.
So people with very dark skin can still get skin cancer. However, it is protective, because the pigment within darker skin does absorb ultraviolet light and does protect the deeper levels of the skin. So it's certainly, you're really, the color of your skin means that you can withstand a higher dose of ultraviolet light before you burn. But everybody of every skin type can get skin cancer.
So there's another question coming here. Using a daily facial sun protection factor containing cream, what factor would you recommend?
So we did a little bit of research into this. We wanted to compare basic moisturizing creams, which very often now will have SPF factor in them, with a sunscreen. And what we found was that the protection, or the amount of sun protection through the moisturizing creams, was not as good as the bespoke sunscreen. So the first thing to say there is, if you really are trying to, if you're going out in strong sun and you're trying to really protect yourself from burning, you need to use bespoke sunscreen. However, on a daily basis, if you want to just generally protect your skin and you're putting on moisturizer every day, it would seem reasonable to have something with SPF in it. Because it appears to be less effective than bespoke sunscreen, we'd probably say, you know, have the highest factor that you can. You might then also want to factor in the fact that you might be producing less vitamin D if one of the only areas that is exposed is having reduced UV. So some people would say, I'm going to reduce my skin cancer risk and burning risk with sun protection, and I'm going to take a vitamin D supplement. The vitamin D biology is an area that is evolving. We don't know everything about it, and I suspect we'll find out a bit more through the COVID crisis that we're going through. So that's something to watch in the future.
Okay, very good. I'm very aware that I've only taken questions from the text here. So if anybody has a question they'd like to just say out loud to any of the people who've presented so far, this would be a good opportunity to take yourself off mute and you can offer those questions. There is, Austin, there's quite a complicated question on Gorlin-Goltz syndrome in the text. That's probably something that you can address via text, because it's beyond my expertise, that one I can't.
Okay, so I can't see that. I can see a question here from, would I recommend to put sunscreen independently from sun presence, like on cloudy days? I think, so each of us as an individual, we'll have a certain, based on our skin pigmentation, we'll have a certain amount of time before we burn, and that is based on the strength of the sun. So you, on cloudy days, that really does reduce how much ultraviolet light is getting through. But actually, if you spend a whole day under an overcast skies, you can still get burnt. So I think it's about assessing the amount of UV that you're expecting with your activity. You're out for a short period of time, and it's overcast, you're actually probably going to be fine. But if you have a significant amount of time, you should consider using sunscreen. The golden goats question, I can't see that, Kevin.
Okay. So from your experience, have you ever come across a patient with golden goat syndrome? How would you manage recurrent basal cell carcinoma in such a case?
So we do have some people with that syndrome in our clinics, and every oculoplastic surgeon will do. The difference, just to explain, Gorlin-Goltz syndrome is a condition whereby people have a genetic problem that predisposes them to have basal cell carcinomas. And so they get multiple basal cell carcinomas over their lifetime. And the difficulty, therefore, is using surgical treatment is you keep removing skin and keep reconstructing, and that can then start to have an effect on appearance, and you may run out of skin for reconstruction. Where possible, if we can use non-surgical techniques, we may do that. So if it's in a low-risk area, away from the lid margin, away from the eye, we might consider cryotherapy. So elsewhere in the body, cryotherapy is quite a common technique for treating basal cell carcinoma. It's got a higher recurrence rate. So where possible, we, as periocular surgeons, we would use surgery, because we recognize that BCC around the eyes is a higher risk area. We want to be as sure as possible we've got rid of it. But with Gorlin-Goltz syndrome, where we know that there are going to be repeated basal cell carcinomas, sometimes we will use cryotherapy and observe closely. But ultimately, we have to treat them like everyone else. We have to get clear margins of excision, particularly in high-risk areas like the inner corner of the eye, the medial canthus. So we carry out quite a bit of surgery for them.
And there's just another question appeared about your career path, actually. So they want to know why you combined ophthalmology with oculoplastics, and was there, what was the motivation and the length of time it took to qualify, and even how many of them are there in the UK?
Well, we have our own society, the British Oculoplastic Surgeons Society, that meets, well, it should be meeting fairly soon, but isn't going to this year, and about 350 people will attend. But there's probably around about 120 consultants in the country, something like that. Not all of them will be 100% oculoplastic surgeons. They'll be ophthalmologists doing some general work as well. I chose it because I like operating. There's a huge amount of surgery involved in my job. It's incredibly varied. So I do craniofacial work at Alder Hey. I'm involved with the neurosurgeons, with the head and neck cancer surgeons. So on a single day, I might be removing a small, warty skin tag, and then I might be doing some neurosurgery in the afternoon. So for me, that's what attracted me, a really, really interesting job with a huge variety in it. It's a relatively, we're all ophthalmologists. It's a relatively new specialty. So within the last, I would say, 30 years, it's really grown as a separate entity and continues to grow.
Okay, I'm sure a lot of patients get referred to you then, because it doesn't sound like there's a huge number here.
There is, and unfortunately, we do have probably too many patients than we can realistically deal with. We deal with problems such as blocked tear ducts and watery eyes, and inevitably, particularly at the moment, we have to prioritize people with skin cancer over that sort of problem. It doesn't diminish the symptoms of people with blocked tear ducts in any way, but some choices have to be made. So I think the more you provide specialist surgeons, the more operations are available, the greater the demand. I think as ophthalmologists, we've seen that. Professor Harding showed how the department has grown over those years, and you wouldn't say that pathology is increased by that number. It's just the available treatments, the available operations, and the expertise has grown, and therefore demand grows.
Very good. So I think we should move on to our final pair of speakers, actually. So I think Vito Romano, you're going to go first. Is that correct? Yep.
Shall I share my screen?
Yep. Austin, there are a couple of questions I think you could answer in the chat, maybe.
Yes. Can you see my screen?
Yep, you're good to go.
Okay. So many thanks for Kevin. It's a pleasure to talk to you all. My special interest is the cornea, and I will explain you more about cornea, its importance, its function, corneal transplantation. And will follow me Toby Somerville, and she will explain more about corneal infection. She's a PhD student who works also with us between the Royal Liverpool University Hospital and University of Liverpool. So let's start from the beginning. So this is an eye. The black part is the pupil, and the color part, it's an iris. In front of the structure, probably you can appreciate if you do a cross-section on your eye better, there is the cornea has a dome shape, and is in front of the structure. And its function is to converge the light into the back of the eye, on the macula in particular. So the back of the eye, in this way we can transmit all the vision then to the brain. So it's quite important that it need to be transparent and need to be a specific shape. If you look at the cornea in very details, the cornea is made by an epithelium and its membrane called Bowman membrane, a stroma that is the 90% of the part that is made by fiber that they are packed together and in a way that the cornea is transparent, so the light doesn't interfere with the pathway of the light. And inside there is an endothelium with this membrane called Descemet membrane. And this endothelium's function is to remove water from the stroma and keep this fiber in a particular architecture in order to be transparent. How we imagine the cornea in outpatient clinics you can see we can use some machine that give the cornea shape or the cornea clarity. This is called corneal tomographer or optical coherence tomography. And then there is some other machine that you are able to imagine this mosaic. This is the endothelium. This is the inner layer of the cornea, as I said before. And we can use a machine like a confocal microscopy or a specular microscopy. So as you can understand, that the main important things are the shape, change in the shape like happening in keratoconus patient. There is a bulging of the cornea, and this affects the vision because the light is not able anymore to focus on the back. Or there is a dysfunction of the endothelial layer, and then this causes the accumulation of the water in the cornea is becoming opaque, and this again, the vision is, the patient is not able to see after that because the light is not focusing the back of the eye. Or there is a scar that normally infection end up with a scar. If this scar is in the center of your cornea, it's in front of your pupil, again, can affect the vision. To make you understand clear, this diagram probably will, you have a good vision, so the light is transmitted well through the cornea and is converged on the back of the eye. If you have a corneal disease, you have a reduction of vision because they have light scattering. So until the first years of the 20th century, this disease caused blindness and were not able to recover the vision. But in the early years of the 20th century, thanks to an Austrian surgeon, Edward Zirm, did perform the first corneal transplantation. Since then, it's moved a lot different kind of technique. So penetrating keratoplasty, where you replace all the cornea, with means that all the 5 layer, and then you can have an anterior lamellar keratoplasty where you keep the endothelium and the Descemet membrane of the recipient, and you replace just the stroma and the epithelium. This kind of, they have different graft survival. They are attached with this stitch that after 1 year we will remove it. Then we have something called the DSEK, Descemet stripping automated endothelial keratoplasty, where we replace the dysfunction endothelium layer with a layer done by endothelium, Descemet, and a part of the stroma. Or we have an ultimate technique that's called DMEC, where we use just we replace the dysfunctional layer with just endothelium and inner layer and the desmet layer. So on your right side, as you can see, this optical coherence tomography with different kind of shape of the cornea and a different kind of recovery vision. All this surgery rely on the corneal donor. So you need to know, as you can see from this graph, there is a lot of countries that are self-sufficient. Some are good to export also the cornea, like Sri Lanka, Italy, and USA. But there are a lot of countries also that are not sufficient, or they don't have at all this kind of service. So the calculation overall is one cornea available for 70 needed. So it's essential to develop alternatives. The main indication are endothelial dysfunction, stromal disease, or infection and scarring. So everyone needs to know that each of us, when we pass away, we are donor. It's important to tell our relatives, our parents, the people that live with us, that we won't donate our eye, because the donation makes the difference for so many patients. The eye bank is able to retrieve the tissue and then ship to the surgeon. This, I want to show you something, this how make a difference. So this is a patient on the right, on the left, you can see that with endothelial dysfunction, and this after 6 weeks, patient that recover. So this, her life changed a lot after that, and this will make a difference. So the donation of the corneal donation make a difference in a lot of people. I will tell you more about our research at the moment with the Liverpool Research Eye Bank that it's based in our University of Liverpool. We're working on artificial corneas, and we try to replace, so to find alternatives for these donors, because as we know, there is a huge demand. And other project that we're working close with the eye bank is use one donor for more recipient. As you can see from the picture below, you can see how is stored the cornea. Is stored in this medium. That's it's red. This medium. Then we can prepare the tissue and separate the tissue, the desmet membrane, and then the endothelium will go to one patient and the stroma to another patient. So in this way, we try to amplify our pool of cornea, our donors. Other things I want to highlight, that the corneal transplant is the most successful transplantation that we can have in the body. The survival rate is 72% at 5 years and does not require any systemic immunosuppressive treatment, but topical drops that most of the times after 2 years become once a day, so it's become easy to, the compliance for the patient is very easy. So I thank you, and then I think I pass the straight to Toby, and or if you want, we can make a question now.
Great. Can you see my slides?
Yep, you're good to go.
So my name is Toby Somerville. I'm a PhD student at the Department of Eye and Vision Sciences at the University of Liverpool, and I'm also an ophthalmology registrar based at St Paul's Eye Unit. So in this presentation, I'm just going to talk briefly about corneal infection. So I'm just going to give you a warning. My next slide does contain some graphic pictures of some corneal infection. So what is corneal infection? So corneal infection is an infection of the cornea, which Vito has just described is the clear front window of the eye. You may also hear the terms microbial keratitis and corneal ulcers used in the eye clinic, and basically what we're referring to is corneal infection. We see a wide variety of presentations to our emergency clinic at St Paul's. So patients typically present with a very painful red eye. They may find that light is hurting their eyes, their vision may be reduced, and their eye may be watering. So we see, so the image on the left-hand side of the screen shows a small area of infection here that I'm circling with my arrow. Two much larger areas of infection here that you can see. And these can also be associated with collections of inflammatory cells in the anterior department of the eye, and this is called a hypopion. So why do we worry about corneal infection? Well, what we really want to avoid is corneal scarring that you can see in this picture down here. And this is what can happen if we treat these infections inadequately. And this is essentially what leads to blindness. So how common is corneal infection? Well, there are approximately 6,000 new cases in the UK per year. We see roughly about 250 cases to our St Paul's eye unit per year. So who is at risk for corneal infections? So usually for corneal infections to occur, there needs to be some sort of corneal disruption to the front surface of the eye. So the most common risk factor in the UK is contact lens wear. And this is because of two factors. So contact lenses can cause a mechanical disruption to the front surface of the eye, but also some bacteria love the front surface of contact lens wearers. They love sticking and multiplying on the front surface of contact lenses. And some of these can cause particularly nasty corneal infections, such as Pseudomonas. Any condition that causes the front surface of the cornea to be unhappy can predispose you to corneal infections, and these include dry eye, any eyelid disorder that prevents your eyelid from closing properly, as well as any corneal injury. So a scratch to the front surface of the eye is called a corneal abrasion, or any injury that people have received whilst carrying out grinding without wearing safety goggles. Prolonged steroid eye drop use is also a risk factor for corneal infection, as are some virus infections. So patients who have cold sores or chickenpox or shingles, the viruses that cause these infections, so the herpes simplex virus and the varicella zoster virus, can also cause corneal infection. So what causes corneal infection? So predominantly in this country, most infections are caused by bacteria, and these are mostly caused by opportunistic bacteria that live around the eyelid or eyelashes. A small proportion of infections are also caused by fungus, and these are more relevant in countries such as India in tropical settings. Also, trauma with vegetation is also a risk factor for fungal infection, as are prolonged use of steroid eye drops. A very small proportion of infections can also be caused by acanthamoeba, which is a parasite infection, and this can be found in water or soil. It is typically found in tap water, hot tubs, swimming pools, and that's why we strongly advise patients who wear contact lenses not to swim or shower in their lenses. And as I touched on before, a proportion of corneal infections can be caused by viruses. The herpes simplex virus and the varicella zoster virus typically lie dormant, and they can be reactivated in times of impaired immunity, stress, or sunlight exposure. So how do we diagnose corneal infection? So it is extremely important that we take a corneal sample so that we can identify the causative bug that's causing the infection. So traditionally, we have done this by scraping the area of infection with a blade. However, it is extremely difficult to identify the causative bug using this technique. There is quite a low positivity rate using this technique. So in Liverpool, we try to optimize the sample collection, and we developed the corneal impression membrane technique. And we have demonstrated that this technique is much better at being able to detect the causative bug that's causing the infection in these patients. It is also, as you can imagine, much better tolerated by patients as well. So how do we treat these patients? So typically, we treat these patients with antimicrobial eye drop treatments. Now, depending on the severity of the infection, these are typically started hourly and often through the day and night. Depending on how bad the infection is and if we think the patient will manage the drops over home, we often ask the patient to be admitted as well. And depending on So if the corneal infection does erode through the 5 layers of the cornea, leading to a corneal perforation, or if the infection does lead to large amounts of scarring, sometimes the patients will end up having corneal surgery as well. So although corneal infection in itself is fairly uncommon, I have put together some do's and don'ts to help prevent this from being developed in the future. So some do's for everyone. Do wash your face before going to bed at night, especially if you're wearing makeup. Do use artificial tears if you suffer with any ocular surface problems such as dry eye. Do use protective eyewear if you are doing at-risk activities such as using power tools or grinding. And if you do sustain an eye injury, do seek help from an eye specialist immediately rather than sitting on it for a few days. If you're a contact lens wearer, do wash your hands thoroughly before handling the contact lenses. Do use commercial contact lens cleaning solutions rather than any homemade variations. Do clean and sterilize your contact lenses before and after wearing them, and avoid wearing your contact lenses for prolonged periods of time. Some definite nevers: do not ever use tap water or saliva to moisten or store your contact lenses. Do not shower or swim in your contact lenses, and this is particularly relevant to the acanthamoeba infection that I was talking about earlier that can cause a particularly nasty corneal infection. And do avoid sleeping in your contact lenses unless you have been specifically advised by your contact lens manufacturer. So just to touch a bit about the research that we're doing at St. Paul's Eye Unit on corneal infection. So we're currently conducting a study using the corneal impression membrane to try and better identify those bugs that are causing the infection. So we are taking membrane samples from both of the patient's eyes who present with corneal infection to try and get an understanding as to which of those bugs we isolate are causing the infection and which of those bugs are just living on the front surface of the eye. We're also taking samples from the patient's eyelid margins, conjunctiva and nose to try and get a better understanding as to whether these bugs that live on these surfaces also contribute towards corneal infection. We've also carried out research with our partners in Malawi. So Malawi is a southern eastern country in Africa. There are large numbers of corneal infections in Malawi. At the moment, there is no way of taking corneal samples to identify the cause of the infection in Malawi. And we basically use the corneal impression membrane sampling technique to take samples from these patients. And the results have significantly impacted the treatment protocols out in Malawi. So I think that's it. So thank you, everybody.
Very good. We've had a few questions come in, but Vito seems to be on top of the chat quite nicely. I just want to highlight a couple of them. They asked about how you would clean your contact lenses. What's the best way to clean them? And I think you kind of picked up on that in the end. Commercial properties are the way to do it, and disposable lenses are obviously better in terms of less likely to get a bacterial infection. There's a question that just came in very recently. Will small corneal abrasions heal itself naturally? I think the answer to that is usually yes, very rapidly. The cornea has actually got an amazingly rapid wound healing response. I'm actually into an area where I know some stuff myself, but I should really defer to Vito and Toby, I guess. And then I just wanted to point out, because we're getting toward the end here, and I know some people will have places to go, and I do want to keep on taking any questions or anybody has anything, but just in case you do have to go, I want to highlight very quickly that we have a number of other sessions going on this week. And one of the bigger ones is the Meet the Expert session, which is on Saturday, the 6th of June at 10 a.m. And in that session in particular, we'll take questions in advance or on the day about anything really. And on the panel, we have Professor Rachel Williams, who is a professor of bioengineering, ophthalmic bioengineering, who's developed silicone oils like Victoria talked about for treating retinal detachment, but is also working on antibacterial contact lenses. So she's coming at it from a treatment point of view. So she's going to chair the panel. We'll have Mark Batterbury, who's a consultant ophthalmologist, Simon Harding again, Professor Harding here, Teresa Sandina, all three consultant ophthalmologists, but with different specialties. So we'll cover most common eye diseases. Then we have Tom Sharp, an optometrist, and myself as a biologist in the group. So that'll be a really good session on Saturday, and you can sign up via the same website that you used to sign up to this one. I'll put that link in the chat, but you'll also get an email immediately after this session to remind you to do that, because it should be really good. What else? So would anybody like to ask anything just now? Oh, here's a good question. Oh no, sorry, I've misread. It was Vito asking the question. So once again, if you like to talk at this point, you should be able to unmute your own microphone. There's the bottom left-hand button. So if you haven't been able to type anything in and you'd like to ask a question now before we go on our merry way for today, then please do so.
Kevin, I'd just like to thank you and all of the presenters and the guests for turning up today. It's the first time we've done this, and I think it's been very enjoyable, informative, you know, and I hope everyone feels the same way. But thank you so much for all of you giving your time to get together and make this webinar a success, I think.
Thanks, Tom. As Simon said earlier, we couldn't have done it without you. You set everything up. I would also point out to everybody who's on the chat, we would like feedback, because as we said, it's the first time we've done it, but if it's something that people like and enjoy, we'll certainly do it again. The recording of this this whole webinar will become available as well once we work out how to host it somewhere. And I guess I may have forgotten to mention that we've done this with support from Medicash as well, who are another 150-year-old local charity that supports an awful lot of research and well-being, and we couldn't have done it without their support as well. I don't know, Tom, if you want to say anything else in that area?
Yeah, as well as Medicash, I'd really like to thank the whole of the university as well for their support, especially with the technical side of creating these webinars. You know, we had to adapt pretty quickly when we realised we had to cancel the whole of the Eyes Revealed programme, which obviously was a live one, public exhibitions. And I just don't think I would have been able to do it without the technical support of the university, and having you, Kevin, guide me, and everyone having technical advisors. So as well as Medicash, I'd just like to thank the Institute as well, please.
Very good. Well, I guess the last people to thank are everyone who's turned up to listen. Thank you very much. I hope you found it useful, and I hope yeah, we'll see you on Saturday, or maybe you'll see us. Who knows? Okay. Thanks, and thanks again.